actually attached to, they don't have it drawn real well in this picture, but those flora are attached to the thoracic cavity wall. So if the diaphragm and the rib cage move, along for the ride comes your visceral and parietal flora, and along comes the lung tissue as well. So it's not just the movement of those muscles, it's also bringing along those flora and the lung tissue to help expand or contract the size of the thoracic cavity. All right, so that's pulmonary ventilation in a nutshell. This IP10 has an entire scenario on pulmonary ventilation. So if you'd like to walk through it perhaps in a little more detail, try out their respiratory process on pulmonary ventilation. How about questions so far? What's that? Is there anything I can answer for you now? Okay. Okay. Take the IP10 because I think it's got 20 slides that will step you through every single part of the process. But yes, keeping track of volume and pressure, and that's mainly what they focus on there. Okay. Okay.
Internal respiration of carbon dioxide is tissue to capillary.
Tissue to capillary, right.
And oxygen circulation.
Right, right.
Internally with capillary to tissue or tissue to capillary?
Depends on which gas. If you're talking internal respiration, if you're moving from tissue to capillary, that's CO2. If you're talking capillary to tissue, that's O2.
Carbon dioxide is loaded or unloaded?
We say it's loaded. Carbon dioxide, yeah. In the internal respiration, it's loaded. Yeah, oxygen is unloaded during internal.
I think I'm going to for the people that you wanted us for the order that you wanted us to go, it said you want to know all the things, you said one or two of each, or?
Just, yeah, no, I don't want to list like this, but just so you could talk about it. If somebody said to you, what's asthma, you can talk about what causes it or what some of the symptoms are. Just, you know, one or two would probably give it enough. So. This was one of the items on your list of homework to look at, so I wanted to just briefly mention it to you since I have an animation here or a picture of it for you to look at. Asthma is inflammation of the air passageways in the lungs. You can see down here in the bottom picture, if the air passageway is patent or open, that allows for more air to be able to travel into the lungs. But if inflammation results, or if that air passageway constricts, look what that does for the chances of getting enough air into the lungs. So what are some of the symptoms then of asthma?
Wheezing.
Wheezing. Why wheezing?
Just constricted.
Exactly. Air's trying to go through this constricted passageway, so you might hear wheezing when the person breathes, or there may be coughing and other things to try to help open up those passageways. Why is epinephrine a good source of medication for opening up the breathing passageway?
As a dilator.
It dilates, good. Dilates the breathing passageways, so it takes something that may be restricted in what you see here and opens it up so that the air can pass more easily into the respiratory system. So I know it's hard to tell somebody who's having an asthma attack to relax, but, you know, that's part of it, you know, is to calm, breathe, you know, but also epinephrine can actually help to dilate those breathing passages. Yeah.
Yeah, I was reading about asthma. It says that you can have like skin problems from asthma.
I don't know about, I'm sure there probably are. Eczema, yeah. Yeah.
Wow, you know,
I don't know what the link is. I can look and see if I can find out if it's autoimmune or whatever. But I sure don't know what the link is. Alright, so here you can of course see the difference in the passageways there. This is an immune response actually. You know, people that have allergies can have allergens trigger this response and promote inflammation. So that's why it's important for someone with asthma to really watch during those allergy seasons for inflammation of those breathing passageways. I also want to mention to you this disorder because this is a complicated myth. We just talked about asthma, but I also wanted to talk to you about bronchitis and emphysema for just a moment. What's bronchitis?
Inflammation of the bronchi.
Good, inflammation of the bronchi, so you're talking about possibly an infection, for instance, or a cold that's settled in your chest. What about emphysema? What happens to those alveolar air sacs during emphysema? They kind of collapse, they kind of are like blown out balloons. I'll show you a picture in just a moment. And as soon as y'all are copying this, I'll give you a moment to grab that slide. So, you know, since this is a chronic condition, this is something that's typically a long-lasting condition and also does not go away on its own, if at all. This is a great picture for seeing how COPD can destroy those alveolar air sacs. The air sacs in your lungs, essentially, if laid out flat, would be about the size of a football field. How incredibly large that is. You think, well, why do you need so much surface area in there? Well, why do you need so much surface area? Good, exactly. For the gas exchange process to occur, to get enough oxygen in and enough CO2 out, those alveolar air sacs have to have so much surface area for that gas exchange. You can see what COPD does to the alveolar air sacs. It decreases the surface area. So what do you think that does for the gas exchange? Also decreases it, exactly. So a person with COPD may have difficulty getting the oxygen in or the carbon dioxide out, simply because you've got issues here with the surface area of those alveolar air sacs. They call this functional efficiency. So loss of surface area means the lungs are less efficient at doing that gas exchange. So there's no way I could possibly describe to you what this picture actually shows. So I think it's a great picture for showing you how those alveoli are essentially destroyed by a chronic disease like COPD. And again, here's another shot where you can see those normal alveolar air sacs down here on the bottom right. And then notice the loss of those alveoli up here on the top left. Much less surface area on a COPD patient. All right, just a couple of items there on the top of page 80, and then we'll hit page 81. We talk a little bit about lung collapse, which is mentioned up there at the top of page 80. Down below, you'll notice there's 3 factors for influencing the passage of air into and out of the lungs. You know what? This sounds really familiar. This sounds like the blood flow through the blood vessels. Notice one of those factors influencing pulmonary ventilation. The first one is airway resistance. Let's go back to the asthma picture for just a minute, because that's a great way to kind of understand airway resistance. Think about the way your blood vessels work. All right, so if you have an obstruction to the flow of air, that's airway resistance. That means it's more difficult for air to get into your lungs. So something like asthma does what to your airway flow? Constricts and decreases the flow of air. So the diameter of our breathing passageways can actually influence how much air gets into our lungs or out of our lungs. The other item there is alveolar surface tension, and I'll go back for just a moment to a previous picture that you've seen. We've talked about surfactant in the past. What does surfactant do for those lungs? Good. Reduces the stickiness between those alveolar air sacs, so So instead of having those alveoli stick together and collapsing the lung, the lipid substance that makes up the surfactant repels the stickiness and keeps those alveolar sacs open. So the stickiness, you might say, is also an issue here for this process of gas exchange. Lung compliance we also talked about a few minutes ago. That was our flabby underwear example. That is how recoil those lungs are, how much they can recoil back to their original shape after they've stretched from inhalation. If you have poor lung compliance, what does that mean for exhalation?
Incomplete.
Incomplete. So people who have poor lung compliance may have to forcibly exhale air. You ever seen somebody breathing and going,
Barrel chest.
Barrel chest, yeah.
CO2.
Yeah, the CO2 can't escape because the lungs can't recoil, and if the lungs can't recoil, what stays trapped in these air sacs?
CO2.
CO2. So they become barrel-chested, they're really forcibly breathing, and the process of exhalation is normally passive, meaning we don't require what? ATP. But in a person who has poor lung compliance, those lungs don't recoil back to their original shape, pushing out the carbon dioxide.